Thank you. Unlike the previous speaker, I will not say a word regarding transplantation science or organ transplantation surgery of science, but I rather use somehow a demographic approach to try to have a refresh view of the status of pediatric organ transplantation in Belgium. And we know that as adults, children may be afflicted with end-stage failure of an organ that can be replaced through organ transplantation. And obviously these are the organs, the main organs, that can be replaced somehow. And this can lead to some program regarding pediatric organ transplantation. But in all of these cases, actually, alternative management can be developed to avoid transplantation. For instance, in liver disease, we can use biodiversion. For the intestinal insufficiency, we can now develop lengthening procedure. That means that we, in some cases, we can avoid actually organ transplantation. So the hypothesis of this, and I assure I will be brief tonight, the hypothesis of this somehow demographic survey is that first I hypothesize that the need for pediatric organ transplantation is similar in Belgium as in other developed countries. Second, I hypothesize that the pediatric organ transplants are spread within the Belgian academic hospital, because in Belgium by law organ transplantation should take place in an academic hospital. And then the third hypothesis is that considering the post-mortem donor shortage, living donation constitutes an increasing proportion of pediatric organ transplantation in Belgium. So we will try to briefly overview these three questions. So the first question I ask is, what is the need for pediatric organ transplantation in Belgium, in any developed country? And there is almost nothing actually in the literature regarding this. So in order to study the need for the need per million inhabitants of a country per year, for instance, for a given organ to transplant, we actually should consider two types of data. That is, on one side, the annual transplant activity in a given country, and then the waiting list active in the same country at a special time. And then how I made this approach was actually to choose for a country to compare with. And so I looked at the Eurotransplant data. I will talk later about the Eurotransplant system for the non-Belgians here. And there is some data available on the Eurotransplant system, not enough I must say, and there is a big problem of transparency, but I will come back to that. I looked also on the American website, so obviously I choose the United States to have somehow a big comparative country with a big population to try to analyze what is the need for organ transplantation in children. And I must say that on this particular website there are many information, very precise, including for transplanted children. And I also looked at something very interesting I recommend you to have a look at, that is the World Factbook on the CIA website. And you know that they know many things about many countries, and including regarding demographical aspects. So it's very interesting to look at, because for every what country you have something, a lot of data regarding, for instance, infantile mortality and things like that. So actually, I chose to compare Belgium to the United States because the population of the United States is considerable, and somehow the percentage of children in the population is similar. The infant mortality rate is also relatively similar in both countries. So I try, and there are a lot of statistics regarding organ transplantation. So I tried to extrapolate from the US data what would be the need, the theoretical need for organ transplantation in Belgium. That was my method. And so this is a busy table showing, but we will go slowly through it, the number of kidney transplantation performed in the United States last year. And for instance, for kidney transplantation, they performed 687 pediatric kidney transplants among a total figure of more than 15,000 kidney transplants in the whole country, for including adults, of course. This is the figure for pediatric liver in the United States, for the heart transplant in the United States, pediatric, and the intestinal transplant in the United States for 2013 transplant performed. So if you come back to per million, the theoretical need for a kidney transplant in the United States, but probably in many developed countries, would be around 2 per million per year. For liver, it's probably around 1.5 per million per year. For heart, it's 1.2 per million per year. Intestine is 0.1. So that is a total need for pediatric organ transplantation per million. It's around 5 actually. So the theoretical need for Belgium, which is somehow 10 million inhabitants, it's 22 kidney transplants, 16 or 17 something pediatric liver transplant, 12 heart, and 1 something intestinal transplant. That is a total figure of 52 pediatric organ transplantation total per year in Belgium. So now this is a view of the other type of data we need to look at, that is the waiting list. And the waiting list in the United States is for pediatric kidney, it's a bit less than 1,000, liver, heart, intestine. So per million, it gives this type of figures. And so we may have a theoretical need for a developed country of 6 children on the waiting list for an organ, for these 4 organs at least per year, at a given moment. Sorry, at a given moment. So for Belgium, 10 million something, we would expect to find 62 something or 63 children on the waiting list for organ transplantation for the whole country. Right, so how did I get the data for Belgium? This is not easy, and I must complain about the Eurotransplant system, which is absolutely not transparent. It was actually for children, and it was absolutely not easy to look at the pediatric data on their computer system. So actually we had to take, so I just remind you that Eurotransplant system is a community of countries, including Belgium, the Netherlands, Germany, Austria, Slovenia, and Croatia, the 3 C's allocation system. The main advantage of this big community of countries is that when you have a child to transplant in high emergency, you can get an emergency organ from relatively rapidly from this vast population. Otherwise, most of the organs are shared within the particular countries for elective procedures. And so this is the table showing the actual pediatric transplant activity in 2013. So in Belgium we transplanted 10 pediatric kidneys, pediatric kidney recipient in this particular year, when we expected 23 from the United States projections. For liver, we made 39. However, only 11 of them were of Belgian children, because we have quite an activity in Belgium for children coming from abroad. And so 11 versus 16 expected. Heart, we expect 13, we made 4. Intestine, we expect 1, we made 0, actually, for your information. Along these 14 years, we made a total of 6 pediatric intestinal transplantation in 5 children in Belgium, which is a remote activity. So the total of pediatric organ activity in Belgium was 25. and we expected 53. So regarding the waiting list, is very similar. It's even more striking because we have 11 children on the 1st January of 2013, 11 children on the waiting list, again 30 theoretical along the US data, and so on and so on. So it's 37% of the expected number of children on the waiting list, 44% for liver, 33% for intestine. And so the total number of children on the waiting list in Belgium on 1st January was 18, and we expected 63. So the second question I asked, what is the spread of pediatric organ transplant activity? We just understand that the pediatric organ transplant activity in Belgium is relatively modest. And what is the spread of this modest activity? So Belgium is separated in 4 bits by 3 rivers, but the main frontiers in Belgium are internal. I mean the north-southern community, and then the philosophical separation, and then actually we have academic center in these 4 entry of this table. And so we might expect that the pediatric organ transplant activity is spread within all these academic centers. What is the situation? So I kept anonymous the several academic centers, and here are the year 2013 kidney, liver, and heart activity. So 10, we come back to 10. 39, including the center who is doing a lot of foreigners and heart activity. So actually, there are 10 kidney transplants, and most of them are centralized in one particular center. And there are 2 other centers doing 1 a year. For liver, only 2 centers are actually doing these pediatric liver transplants, 37 in one center and 2 in the other center. And the heart, pediatric heart, we have 3 centers with this type of figure. The third question I'd like to ask is regarding living donation in the context of pediatric organ transplantation. And this is an histogram showing the pediatric liver kidney transplant using a cadaveric donor in Belgium during this 10 years, the last 10 years actually, regarding liver transplant, so only cadaveric, and the cadaveric kidney transplant. So the overall trend, as is observed in adult organ transplantation, is that the access to cadaveric donor or post-mortem donors is really with a trend of dramatic reduction only along these 10 years, with the figures here really much less than 10 years ago. And as a confirmation, this is our activity in my center at Saint-Luc Hospital. This is our pediatric liver transplant program, and this is not 10 years, but this is starting from 2006 until the first quadrimester of this year. And these are the number of pediatric liver transplant performed, and the green bars are cadaveric, and the white bars, gray bars, are actually living donors. So the proportion of living donations is really increasing along the time. This is very significant, and the proportion of cadaveric organ used is really in an important reduction along the years. In summary, the need for pediatric organ transplantation in Belgium seems significantly inferior than that observed in the US. So we may discuss about this difference. At first, my hypothesis would be that probably we are working hard on the alternative method to treat, for instance, intestinal insufficiency. But I have no data to confirm this first opinion. That means that something like 25 pediatric organ transplantation are performed per year in Belgian children. This is an orphan therapy. This is very little activity throughout Belgium. And I didn't realize that before, but this is really a modest activity. However, the spread which I expected at first was not confirmed. The spread exists, but it's relatively limited. But we have quite a few centers in Belgium doing only one pediatric organ transplant a year. You understand that there is a dramatic decrease of cadaveric organ donation for pediatric transplantation, and that accordingly there is a parallel increment of living donation for pediatric kidney and liver transplantation. So the challenge I see ahead for pediatric organ transplantation in Belgium, first of all, is to improve the transparency. I think we will need for this orphan therapy, that is organ transplantation in Belgium, more registration of the clinical activity and the results, because it was anecdotal today to give you results about 1 or 2 cases per year. We should work really towards a rationalization of this orphan therapy that is pediatric organ transplantation in our country, because I think we should aim at one single national reference center per organ. And we began this with the intestinal insufficiency. There is no group that is working all the academic center of the north and of the south together to look at difficult pediatric patients with intestinal insufficiency. And there is only one center in Belgium that is dealing with pediatric intestinal transplantation, which is not my center. So I am very happy to send them the few patients that will require intestinal transplantation. This will provide somehow a critical or nearly critical clinical mass, despite the Belgium is so small that anyway we can expect that, including the alternative techniques to avoid transplantation, that the organ transplantation activity in Belgium will remain remote somehow. This type of center, of unique national center, will establish, of course, a multidisciplinary expertise and, of course, collaborate, close contact with all the referencing centers. That is precisely what happened with the intestinal failure approach in this country. This center will, of course, have commitment to teaching and research, and we will need to focus on the development of living donation for kidney and liver recipients. Thank you very much.
Thank you, Raymond. Comments, questions? Well, you try to find the reasons for the discrepancy between the Belgian data and the US data. Does it mean that the point of comparison is the right one? Sorry? Is the point of comparison the right one? I mean, Dr. Winter, how would you explain the difference? I mean, what he said regarding the small bowel insufficiency, I can understand, because you might, as you mentioned, try to avoid transplantation, but for the heart or for the kidney, I suppose they are not kept on dialysis for years. Would you comment, Dr. Winter?
Well, is there any difference in what you define as pediatric? I mean, because
They're right.
American Academy of Pediatrics.
17. We are 15.
They're 15.
Age limit. So it's a little different.
And so I know in the United States there, the American Academy of Pediatrics defines it as under 21. I don't know what UNOS describes it as. That's 17.
17.
So there may be some difference in terms of.
But not accounting so for the 50% difference.
Right.
I mean, this is something strange.
Yeah.
Being a neonatologist, I have not heard anything about interruption of care, interruption of pregnancy, which is, I mean, for real issues, it's quite easy to recognize. For gastroschisis or forageal bowel in a neonate, it's quite common that following discussion with parents that you stop treatment. The same holds true, I think, for heart transplantation. The way we manage, it's more symptomatic, but to the very best of my knowledge, for instance, for left hypoplastic heart, it's not common practice throughout Europe to go for transplantation. It might be completely different in other parts of the world. So I think that's the main driver. If you don't have the denominator of the clinical cases, this is for me as a neonatologist the most likely explanation.
I wonder, as I was thinking about, surely it was a very enlightening presentation, whether or not for specific diseases like biliary atresia and liver transplantation, whether or not you see a difference between the US and Belgium, because there may be some differences in practices about who gets transplanted in the US versus in Belgium. And I wonder if for the same condition, and these data may not be available, because I mean, but if they were, that might be interesting.
Okay, from an epidemiological perspective, as the best of my knowledge, that the biliary atresia is not related to population or ethnicity, or probably the proportion of biliary atresia is very similar throughout the world. Regarding the policy to transplant, I think this is relatively similar. The policy to do Kasai and then to go for transplantation if Kasai fails or if something else happens. I think, to the best of my knowledge, talking with my American colleagues, probably this is relatively okay.
Okay, thank you, Raymond.
In the access to the cadaveric organs, how do you explain this trend?
There is an overall trend to a reduction of cadaveric donation because of many prevention of any sort, road accidents, suicide, therapy for blood hypertension, and everything to prevent development of brain death. So we try to have brain death donors. So the natural history, I think, of cadaveric donation is somehow to disappear.